Good afternoon, everyone. Thank you very much for being patient for this delay. I apologize. Welcome to session Left Main and Bifurcations, latest clinical data applied to practical cases, sponsored by the Medtronic. These are my conflicts of interest. And my spokesperson is Prof. Murasato. And we have a great team of speakers and discussants. Dave Hildig-Smith, Bernard Chevalier, Stéphane Fournier, and Giuseppe Tarantini. So our goal today is to discuss the benefit of large diameter drug-eluting stent, as well as the imaging for left main stenting via practical cases. And we really have privilege to discuss two contemporary left main trials, EBC MAIN and the ROLEX Registry. Then we would like to discuss side branch protection strategy, again via practical cases, and the learnings from another late-breaking trial, the KISS trial. And finally, we would like to reflect on how FFRangio can support decision-making in complex PCI. I would like to invite you to use your either application or standing microphones to actively participate, and please pose the questions. So I would like to invite the first speaker, Giuseppe Tarantini, to start with the ROLEX clinical outcome at 2 years, as well as case presentation.
Thank you, Goran. Dear colleagues, the case of intravascular imaging guided left main PCI from ROLEX. This is my disclosure. Go to the case, male, 70 years old, severe COPD, stable angina, positive stress test, normal ECG, normal echo, and mild renal failure. This is the angio. The right coronary artery seems to be not too bad. And this is the left, where you can find the lesion at the level of distal left main. We have to decide if it is a true Medina or not, and actually we have a diffuse disease also at the level of LAD, mid-LAD. Other two view, because it's important, sometimes it's very difficult to isolate exactly the lesion where it is. This is one of the reasons it's better to not go blind in this kind of interventions and to use many times, the imaging, because you have an added value. So how would you treat? We don't have time to discuss because we have just 8 minutes. We will do at the end of this presentation. But actually, based on the syntax, score, etc., we have 1A indication for PCI and 2A level of evidence B for the IVUS-guided PCI, as I told you, to avoid to be blinded, because actually by angio it's also difficult to adjudicate the Medina in this case. And so looking up a little bit better to the angio, here you can see that we have 4.3 millimeter at the level of proximal part of the left main, but actually it turns out doing IVUS is 1 millimeter larger, is 5.2. The distal left main has an MLA of 3.4 millimeters square. The distribution of calcium is not really severe because it's not to 70 degree or more, and the thickness is there, for sure it's 0.5. But actually, it doesn't seem to be a true Medina, because actually there is 101. And what's next? So our strategy was to go with provisional strategy, following also the general rule of EBC, etc. This is, the procedure is quite standard, nothing special actually. There is a DS 4.5 by 15, is the Onyx XL. We went with a pot, and then we decided to fix protecting the diagonal. That is, again, not a true bifurcation with a single stent in a provisional approach. And then we optimized the things with a balloon. But actually, what is the real focus of this presentation? Here there is the angiographic result, but what is important is to not be blind again, to look at the final MLA. And actually, you can see on the right-hand side, there is 17 against 14, 12, and 6. That is pretty much okay based on the paper of Gary Mintz in terms of future outcome of these patients. So this is the background actually to present in a couple of slides the 2-year result of ROLEX. And this is, I think, the main message. Actually, when you do the angio, you may make mistake in, first to adjudicate the extent of the stenosis, but actually also you may you can do mistake in terms of reference vessel diameter. And actually here you can see from 4 we went up to more than 5. And here, for instance, you have the comparison of angio against IVUS and OCT in the ROLEX trial. The proximal reference vessel by angio was similar, 3.7. But actually, when you use the OCT, you upgrade, you upsize, and you increase the percentage of extra large stents from 14 to 21%. That means in terms of relative risk, 51%. And this matters a lot when you deal with this very important proximal segment. So see, this is just 2 slides to make an overview of the ROLEX registry, registered in clinicaltrial.gov, 450 patients, unprotected left main, syntax score less than 32, 26 sites between Portugal and Italy, and the treatment was PCI plus Resolute Onyx DS. Primary endpoint was a target lesion failure, core lab, and independent clinical events committee. So the inclusion criteria was for sure the left main, at least 70% lesion. In case of intermediate lesion, you had to go for physiology or IVUS, and we included also non-STEMI patients, stable and silent ischemia. So related to the analysis, we had 3 pre-specified sub-analyses: intravascular imaging, isolated left main, and XL stent sizes. This is the 2 years outcome that I'm going to present for the first time. Between 1 and 2 years, we have just 3 events more: 1 cardiac death, 1 TFR in TVR, and 1 TLR. But actually, the stent thrombosis that didn't change, even though we have a significant DAP discontinuation. It was 75%. And this is, I think, remarkable. My last slide is just to show you, I think it's visually is important to see that when you go for IVUS, even in a super adjusted model, including also the center in this adjustment, actually it is visually clear that you drop down the rate of all the events. So the bottom line is it's better to not be blind in this kind of treatment. Thank you for your attention.
Thank you very much. Thank you very much, Giuseppe, and congratulations on conducting such a nice study with such open criteria, and congratulations on excellent 2-year clinical result. Now we go to EBC MAIN, and I would like to invite Dave to present 3-year EBC MAIN results.
Thanks very much, Goran. I'm going to borrow your thing. This new highlighter is really cool, isn't it? I love that. It's brilliant. I've never seen that before. Okay, EBC MAIN 3-year results. So just to remind those of you who are familiar with the study, this was a randomized comparison of the stepwise provisional approach versus the systematic dual strategy for true bifurcation left main stem disease. Treatment was with the Resolute Onyx stent, and we had 460-odd patients enrolled in this trial. This was published a couple of years ago, the 1-year outcomes. And here, just to remind you, are those 1-year outcomes. No statistically significant difference between the 2 groups. A hint about revascularization being more common in the 2-stent strategy, perhaps. So here are the 3-year results. If you look at the primary endpoint, death MI revascularization, 23% versus 29% in the systematic dual, not a statistically significant difference. But in the individual endpoints, you'll see that in target lesion revascularization, there were almost twice as many events in the systematic dual category as in the stepwise provisional, and this was a statistically significant difference. Here are those results shown graphically, and you can see the increase in revascularization events there. Showing the results in a Kaplan-Meier, these are the primary endpoint, and you don't see a significant difference in the separation of the curves here. In target lesion revascularization, though, you do, and this is, again, statistically significant. So that's an important finding, and of course contrasts with some previous studies in this particular arena. So from the study point of view, I think the conclusions are that the outcomes generally are very good with this stenting platform for bifurcation left main stem disease, irrespective in a sense of which strategy you use. There wasn't any specific difference in the primary endpoint between the groups, but there was almost twice as much TLR in the systematic dual stent group. Importantly, only 20% of those who were randomized to the stepwise provisional actually ended up with a second stent, and that's probably the key finding of the study, allied to the fact that, as I said this morning, it's not necessary to decide up front how many stents you're going to implant. That's a key message. And the stepwise provisional, I would say, is the technique of choice in this setting. Now, I'm going to show a case which is slightly the opposite in a sense of what Giuseppe has shown. This is a sort of pragmatic case of a man, 78, with a new diagnosis of what's thought to be treatable lymphoma, anemic, angina on any exertion in hospital. So here's the angiogram. And I think you can see it's a little bit messy. The right coronary artery, you can take it from me, is actually pretty good. But the left main is obviously complex. And here, as is often the case, we talk a lot about complete revascularization, IVUS guided, etc., but sometimes it is pragmatic and practical to do a lesser procedure. And that's why I've chosen this one, because I think many people might look at this and say, I'm going to put in X number of stents, blah, blah, blah. I'm going to use X technique. But in fact, if you just take it stepwise, step by step, you can surprise yourself with the results. He's got terrible hiccups, by the way, which is why it's bouncing around like that. So we looked at this for some minutes in various views. And what we've done is we've taken a 3.25 cutting balloon from left main into obtuse marginal. It isn't the standard approach from the left main, but that's the approach we felt this man needed. This was then a 3.5 I-26 resolute onyx. And this was all done angiographically for a variety of reasons. I mean, I had to bear in mind, in a sense, 60% of the patients in EBC MAIN actually didn't have intravascular imaging. So I wanted to show a case that might be typical there. This was then a 4.5 millimeter short non-compliant balloon for the pot, carefully positioned. And this is the final outcome. And although you could criticize this for not having intravascular imaging, it's been a quick procedure which has relieved the patient of angina, which was his pressing concern as he was about to embark on treatment for his lymphoma. Thank you very much.
Thank you very much, Dave. So I would ask now Yoshi to run the discussion part if we have some interesting questions already arrived. And I would like to invite you all to take the microphones in the room and put your questions.
There is a question about TLR site. Which site is the most frequently occur in the restenosis and the EBC MAIN? Yeah.
Restenosis?
Yeah.
Yeah, so as ever, the restenosis site is the ostium of the circumflex, and actually that is irrespective of whether a two-stent or a provisional strategy was used.
And what is the mechanism of the frequent restenosis in the side branch ostium?
The mechanism of the stenosis. Yeah. Well, that's a more difficult question. I mean, there are many potential mechanisms, of course, involving the fact that the angulation is very extreme. So, forcing the metal to occupy that kind of angulation is tricky. You may get stent strut fracture. You've, of course, got poor rheology. You've got low wall shear stress there, so promotion of restenotic mechanisms through the wall shear stress. Other factors as well, no doubt, but I can't really tell you the answer.
Yeah, if I can ask Giuseppe, imaging was not mandated but was recommended.
Yes,
And
strongly recommended.
yeah, and in a huge proportion of patients, imaging was done. What was the sequence? You just evaluated the final result with imaging, or it was throughout the procedure also to discuss the strategy and then guide the procedure?
You know, thank you, Goran, for these points. So actually, we cannot, in the protocol was not mandate for sure, because actually we cannot do that. But the point is that was done in in about 50% of the cases. But actually, when you look at all the variables, etc., there was a real balance between the patient that received or not the IVUS. And actually, when they use it, they use from the very early beginning for the assessment, for the stent selection, for the stent optimization. So this was the general rule within the protocol. When you use it, you have to use from the very early beginning. Otherwise, it's less, the evidence is less strong in that case.
Yeah. In the group with imaging, you clearly show the reduction in the events. Do you have any data regarding the use of extra large vessel platform?
Yes, the use of extra. So first of all, the two bifurcation were 20%. So this the first important point. This is one of the difference compared to EBC. And actually, we have a sub-analysis of the extra, the XL use that is about 20% again, but actually the sample size is too low to say something more. But actually, this study will be continued for 5 years, and then we probably in a couple of years we can answer better at a long-term follow-up to this very important point, to be honest.
Thanks. Dave, you presented 3 years data, very encouraging. We really see the trend in the direction that we try to promote, that stenting less actually improves clinical outcome as well. I hope we will have more data on longer term follow-up from this study, because at 5 years of follow-up, I'm convinced that we will reach some other statistically significant differences, but this is just my personal perspective. Any comment regarding the use of larger vessel, extra large vessel size stents and the impact of technique in discrepancy, left main LAD, left main circ?
Yeah, I mean, I think being able to use a larger stent is very helpful in the left main. Now, of course, according to EBC philosophy, you'll tend to size your left main to LAD stent based on the proximal LAD diameter. But having said that, and of course that will rarely be more than 4, but having said that, you may want to expand your left main stent up to 5.5, 5.75 or something like that. So you can, for example, use a larger stent frame and, as it were, taper it into the main stem and then take advantage of its larger size to easily get to that diameter within the left main. So I think it makes it a versatile option.
Any additional comments? Bernard, you are one of the pioneers of the left main PCI. With the data just presented on new generation of stent with much better expansion capacity, what is your take on image guidance and stent optimization strategy? I know you will present later on very important KISS trial, but for the left main, KISS was non-left main. For the left main, what is your current practice regarding the imaging and regarding optimization strategies?
We are still very convinced that provisional stent strategy is the best approach for left main in most of the cases, particularly when the disease on the what we call the side branch is not very long. And of course, we use as many teams. We use more imaging It's not yet systematically, mainly for economical reasons, because it's not reimbursed in my country. But we'll use more now OCT, OFDI, this kind of evaluation. I think it's very important. As you said, the capacity of our expansion is also key in this situation. And it's very important to select a stent which can accommodate two different diameters we have to deal with. And in this kind of bifurcation, we have significant difference between the main and distal main branch. So I think it's extremely important to use a stent you know very well in terms of overexpansion.
Yeah. Dave, please, Giuseppe.
So actually, I think there is another point that is, I think, remarkable. So actually, what reassured me in the ROLEX trial is 50% of the patient had an SES. And actually, after 1 year, and was really curious to see the 2 years result, actually 75% of the patient discontinued the dual antiplatelet therapy. I didn't see any signal with this platform of increasing, let's say, very late stent thrombosis. So my question for you is, you have a randomized trial, single versus two stents. Actually, for sure, or probably there might be an imbalance in terms of the rate of dual antiplatelet therapy in the two arms. There is an interplay between the fact that you go for provisional and it's more likely to interrupt the dual antiplatelet therapy, and then in the two stents you will have less likelihood that the people will interrupt within 1 year or 6 months. But actually, I think this is another very important point to discuss.
Yeah, I mean, antiplatelets were left, of course, up to the discretion of the operator. In general, as you stated, the more stents people put in, and of course they put in more in the systematic dual stent strategy, the more they will be inclined, rightly or wrongly, to continue the dual antiplatelet therapy. And we did find that. And we found a few stent thromboses in either arm, actually too few to mention, really. But yes, you're right. The strategies were tailored according to what people had actually implanted.
Giuseppe, I will also ask you a question about stent thrombosis. Congratulations for the ROLEX study. I saw that the rate of TVMI was 5%. Do we have any information about the kind of MI, periprocedural MI, non-STEMI, STEMI, because we are dealing here with the left main, ostial LAD, and there was no signal at all regarding cardiac death. But if you have a stent thrombosis in such a vessel, it can be...
Yes, but actually this is an important point. I'll tell you why. Because actually there were non-fatal MI, and actually were not related to the stent thrombosis in many of these cases. Because actually we have one more myocardial infarction without having a stent thrombosis, and this is pretty much what you can see also in a stopped-up trial. You have something very similar. We don't have to think that discontinuing the dual antiplatelet therapy, all the events belongs to the stent, to the segment treated, because sometimes you leave behind some lesions that are vulnerable, and let's say, going with a short up doesn't mean that you increase the stent thrombosis rate, but actually you may increase, the fact that you have left some vulnerable plaque there. In perspective, I think that the future trial need to be on top of complete revascularization, appropriate complete revascularization, mainly in the acute coronary syndrome, and then we can answer to this point.
Dave, do you remember what was for your patient the APT regimen? Yeah, he was 85, hemoglobin with lymphoma, single stent probably.
Yeah, I will have given him as little as possible. I don't remember for sure, but it will probably have been 3 months in that setting.
Yeah, and
his hemoglobin isn't terrific to start with
85,
for non-bleeding reasons as far as we could tell, but still it makes you slightly concerned that he's going to be prone to bleeding and he can't afford it because his hemoglobin is only 85 to start with.
Not really optimistic. Yoshi, please.
There is a question about side branch lesion length.
Yeah.
The EBC MAIN the side branch lesion length average is 7 millimeter. However, the DK class stenting, the side branch lesion length is more longer, 16 millimeter. So EBC MAIN or ROLEX trial also included such kind of the side branch, long side branch lesion length, so-called definition criteria. How is the long-term clinical outcome of such kind of the complex definite lesion?
Yeah, I think it's a good point. I mean, there are obviously differences between the trials in terms of the geography. So the Chinese trials largely recruited patients with a rather higher syntax score, more extensive disease, longer side branch lesion length, and to be frank, if you have 16 millimeter lesion in your proximal circumflex, it pretty much needs a stent. So it's not surprising that in that study, in the provisional group, about 50% of the patients actually ended up with a stent, and of course 100% in the systematic dual. So they're different groups. So you can say, okay, we have anatomically different groups. We also, I think, to be fair, have a philosophy bias, which I've alluded to before, which is that, you know, for those studies, they've been designed, completed by proponents of the DK crush strategy, and so that, to be fair, they're probably best at doing the DK crush. For the European bifurcation study, probably partly because we deal with a lesser morphology in terms of the severity of the disease, we very much championed the provisional strategy. So to be honest, we're probably better at doing that. So therein lie the reasons for the differences.
Actually, Goran, I think there is something, David, that we need to share with the people, because I don't know if Francesco Burzotto is in the room, but actually we are trying to put in together the data of the EBC and ROLEX for two bifurcation, finally to see in Europe how it's, what is the best strategy when you go with a two-stent technique, if it is decay, if it is culotte, etc. But, you know, trying to put together these things, but we are working on that, probably next year. We will get back again.
Question in the back. Although light is not so good, I'm really apologizing.
Thank you for your
Please.
great presentations. I have related questions about the side branch. We watched two excellent cases which provisional stenting has been performed. But what do you think about side branch ostium strat opening or kissing balloon pod side pod kiss pod? What do you think about this? There's too much data. And we are a little bit confused about that.
I think, Goran, you are the Pope to answer to the point of treating or not the side branch based on Nordic and all the other things, and then I can step in the discussion related to ROLEX. But actually, I think you the man here.
Thank you, Giuseppe. What we have from the perspective of the available evidence is 5-year outcome from Korea, from COBIS-3, and in 5-year follow-up, opening the struts towards the side branch compared to kissing did not show difference in clinical outcome. So equally good went both populations, one with kissing and one with just proximal optimization technique. The other registry is from Dr. Colombo. It's MITO, Japanese-Italian registry, similar design, registry in complex left main, a long-term 5-year follow-up, exactly the same, no difference in outcome. We are biased by the registry design and not by randomized design. We will later listen to Bernard and Kiss data from randomized trial, but non-left main. But for the left main, I think you need to individualize decision, and you need to take into account multiple parameters, not just angiography. The age of the patient, comorbidities, how likely he will have time to develop new lesion in the circ in order to open the door and make access for the second procedure easier. But if I answer on behalf of all this evidence and my personal approach, for left main, which is large bifurcation, I tend to do pot kiss pot. open, remove the struts from the circ, take time to cross distal strut, remove the struts, and then finish with or without final pot. I think the others,
Can I
of
add
course.
something? Yeah, I mean, there's pot side pot. I think is a challenge because you have to be really, really accurate with the position of the second pot, don't you? So I think if you're going to do that, you really need to be sure. To answer your question from my perspective, I think if let's take the circumflex, because it's always the circumflex, if that is not a diseased vessel, then you win some and then you lose some by doing the kissing. So yes, you win some by opening the stent struts into it to make access, but you deform your stent, and you deform it in a way that you can't completely restore with pot. So you win some and you lose some. And at the moment, it looks as though if there isn't significant disease of the ostium of the circumflex, there's no need to do a kiss. But I don't want to preempt what Bernard is going to tell us about non-left main stem.
If I said pot side pot, it's mistake, pot kiss pot.
Yes. So actually, the only things that I feel to add is the degree of calcification of the ostium of the circ, because this is another important variable to take the final decision. Because when you go for kissing high pressure, etc., you create dissection. So you need to, in this case, sometimes to foresee a two-stent strategy. But actually, I think I cannot say better than Goran said before. Actually, it's really individualized.
I would like to have a comment. According to Japanese 3D OCT bifurcation registry, we confirm the guidewire recruitment point under the 3D OCT guidance. And angio-guided guide wiring success rate is only 66%. In the previous study, the angio-guided distal wiring success rate of only less than 70%. So kissing balloon inflation, around 30% fail to perform the complete performance for open up the side branch. Under the 3D OCT guidance and using the short balloon or short balloon overlapping, side pot is work very well. And pot balloon should be located at the cardinal site, and sufficient expansion in the polygon is very important point for the side pot procedure. Imaging guided such kind of finding of the confirmation, we can do the similar result for the pot pot.
Stefan, what's your practice?
Well,
open or not the struts towards the circ?
Normally, I open the struts every time, but I also do the same as you propose. You have to pay attention with the vessel you are dealing with, and the ostial circumflex can be challenging if you have calcium. So if we have any doubt, we perform OCT also, IVUS.
And word of master at the end, Bernard.
I think we need to randomize on do kiss left main.
Do kiss left main. I like the idea. And I think we stop at this point and we shift to the second part and need to learn, Stefan, from you how to use angio-based physiology in the cath lab. This may help us perform better our interventions and improve the procedural result. Please.
Thank you very much, dear panel, dear friends, dear colleagues. Thank you very much for this kind invitation. During the next couple of minutes, obviously, we will also discuss bifurcations, but here we will see how physiology can help us. We will not discuss any physiology here. We will discuss wire-free physiology with the use of FFRangio from CatRox. So to illustrate how physiology can help us, I selected a very usual case that you see maybe every day or every week in your cath lab. This is a very typical story. Quite young patient with 3 cardiovascular risk factors. He told us that he has been recently investigated in a private clinic for typical chest pain. He had a coronary angiography. We did not have any information, but he told us, apparently I have a multivessel disease and I'm waiting for the phone call of the cardiologist because they are discussing cabbage or PCI. However, the patient was admitted in our hospital for chest pain. He had a clear unstable angina and the high sensitive troponins were extremely reassuring. So we decided to repeat the coronary angiography in our center. This is what we saw on the left system. You can appreciate a very tight stenosis of what I will call the third marginal at the ostium. It's a quite long vessel. Here we don't see a lot for the LAD, but in this view, we also observed intermediate stenosis of the proximal LAD. So at this point, it was quite a surprise for us to speak about CABG in this patient. He was not diabetic additionally, but we still had to look for the right coronary artery, and we were waiting for something awful. But it was quite a surprise. The right coronary artery looks almost normal. So for us, it was quite clear that there was no discussion for CABG in this patient, and our strategy was to measure first this intermediate stenosis of the LAD. But there is a way to do it faster. And what could have been done during the RCA injection? Well, you can ask a fellow, you can ask a nurse to transfer the images of the left that you had, to transfer them to the console of CAT-ROX, FFRangio. And from the routine angiograms, you can build, a 3D full tree, and you can predict the FFR. You obtain this nice FFRangio color-coded map. And in our case, well, the FFR in the LAD was significant with a value of 79. You can nicely appreciate that it becomes significant directly after the proximal stenosis. But you not only obtain information about FFR, you also obtain information about the angulation, that will help you during your PCI. It is on the left side. Cannot move my mouse, yes. And you also have some insight about the length of the stenosis. So this is quite useful as a tool. In Lausanne, we perform a lot of studies about physiology, and in these cases, we also perform invasive FFR. And here you will see that the resting PDPA was 0.90, and the invasive FFR was also significant in the LAD, 77. By the way, we also had the confirmation that the third marginal was sick with an FFR value of 0.74, and we also had some information about the good angulation to help us for the work to be done. So our decision was to treat the circumflex into the direction of the third marginal with a provisional stenting regarding distal LCX, and to repeat the LAD in a second procedure. So it was a predilatation of the third marginal with a small balloon. The results after the dilatation, stent implantation. Here you already see that there is something happening in the ostium of the distal circumflex. POT, and the results after the POT. And here obviously there is something happening. It can be plaque shift, carina shift, you can call it how you want. And here again, if you don't know what to do, you can use these tools. And this is what we did with FFRangio. So you don't need to have a new wire. You can have this information almost live. And here, the distal circumflex was suddenly significant with the use of FFRangio. We measured it also invasively, and it was the same result, 79. And we decided to treat this distal circumflex with a culotte. So we opened the strut, we did the predilatation, then we implanted the second stent. Did the POT, kissing, and a final POT. This is the final angio. And if you have any doubt, well, guess what? You can still do your FFRangio. In this case, the result was good because the FFR at the end of the procedure was 88. So the take-home messages is that angiography-derived FFR works. It helps you. And also in bifurcations, we have nice clinical data coming from FAST FFR, which was published a few years ago in Circulation. The accuracy with invasive FFR is excellent. And here, I think this is a tool that can be useful in this kind of lesions that you don't want to cross a lot of time because it's time-consuming and it might be challenging with the wires that we have to measure FFR. Thank you very much.
Thank you, Stefan, very much. Now I would like to invite Bernard to present the design, already mentioned several times, the KISS trial, and we need to learn more.
Thank you, Goran, ladies and gentlemen. So provisional stenting strategy is recommended in most of the bifurcation lesions on the role of systematic side branch opening. It's still a matter of debate. There are some arguments for side branch intervention to get a better rheology, to have a less side branch occlusion, less periprocedural injury, and maybe a better relief of angina and less restenosis. On the opposite, you have some arguments against side branch intervention in order to achieve a shorter procedure time and less radiation exposure, less risk for side branch dissection, less need for second stenting, and maybe have a positive impact on the risk of restenosis. So the trial here was trying to evaluate that, and we picked any de novo non-left main bifurcation except Medina 001 requiring a wire-based side branch protection. Side branch should be large enough to accommodate a coronary stent, at least 225 millimeter stent. And the main branch stent, which was a Resolutor Nix, was sized to distal reference diameter with a systematic proximal emboliization technique. Having done that, when the side branch is patent with no flow reduction and no sign of ongoing ischemia, the patient is randomized between the study group with no side branch intervention versus the traditional approach recommended by EBC, which is the side branch intervention using kissing balloon technique or pod-side-pod sequence. The primary endpoint, because the first target of opening the side branch is to ensure the safety of intervention, was the rate of periprocedural infarction injury using the R2 definition for the first 2 days after the intervention. And I will show you also some secondary procedural endpoint and the secondary clinical endpoint at 1 month. 12 months data are not yet available. We randomized 1,617 patients, 304 in the study group, 313 in the control group, and per protocol analysis, we have lost some patients because of poor compliance to marker evaluation, to cardiac marker evaluation. The study was sponsored by CERIC, the account giver was Medtronic, and the CRO organization was CERC. And I have to thank the CEC member, Professor Barbato, Professor Mori, and Dr. Louvar. The study was performed across 6 countries in 20 centers, and it's an opportunity to thank them, particularly the top 3 enrollers in Nîmes, Toulouse, and Massy. We can see that the clinical characteristics are very classical. It's mainly stable patient, good ejection fraction. We have more previous MR and more previous PCI in the control group. The risk factors are quite similar. And baseline troponin was normal in 2/3 of patients. It's mainly radial access. Medina XX1 were 30 and 38%. With significant difference in control groups. Again, like in many bifurcation, it's mainly LED. You can see the proximal distal main diameter and side branch diameter. You can see that the Finet-Murello is followed in this case. 32% rate of side branch stenosis, very short lesion, 4 to 5 millimeter long in the side branch. POT was done in almost all patients, as we can see, and in the control group, there was the distribution of pod-side-pod for 57% of cases and kissing KBT in 33%. You can see regarding the primary endpoint, the rate of periprocedural myocardial infarction. There is no significant difference in terms of superiority, but non-inferiority is met for no side branch intervention, 4.1% versus 5.7%. And we have almost exactly the same data regarding per protocol analysis or as treated analysis. Interestingly, in the control group, which was a side branch intervention, there is a strong trend for less events in the pod-side-pod sequence, 3.4%, versus kissing balloon technique, 8.9%. What about the secondary endpoint? Technical success was similar. We saved, of course, time, 11 minutes less. We saved some fluoro time. We saved some radiation, significant difference in terms of radiation exposure, X-ray exposure for the patient and for the operator. We saved some contrast volume. Of course, the acute gain is different when you intervene on the side branch. We have 0.10 gain in the side branch versus minus 0.4 if you are not performing side branch intervention. But you can see that this difference, even if it's significant, is not so huge. At 30 days, there is no significant difference in terms of clinical endpoint. So we can conclude from this data so far that provisional stenting in routine non-left main bifurcation using radiotonics is associated with good short-term outcome in the absence of any side branch intervention when stent is sized to distal reference and if side branch is patent after systematic POT. This strategy is associated with reduction in procedural time, contrast media volume, X-ray exposure, and less requirement for double stenting. Of course, we need to get the midterm follow-up, maybe a PCR next year, to confirm the potential benefit of this strategy simplification. I thank you for your attention.
Thank you very much, Bernard. Can I start the discussion by asking, is this the end of kissing in non-left main?
I think if the side branch is patent after stenting the main, it's very difficult to find a good argument to perform a systematic kissing.
So 50% diameter stenosis with TIMI-3 is acceptable.
Leave it alone. Yeah.
Leave it alone.
So
I think
how do we deal with the side branches? If we measure an FFR, which is significant, but you don't have any evidence of flow reduction, no sign of ischemia. We let the vessel as it is, or we have to further dilate the vessel?
I think we have to leave it alone. We have to let it.
Did I see right that 30% were XX1?
Yes, 32%.
So 30%, as it were, true bifurcations.
Yeah.
Okay, so there may be a difference potentially between those who are and aren't true bifurcations?
We evaluate the interaction between Medina XX1.
Yeah.
We evaluate the interaction with more than 50% by QC analysis from the core lab. We evaluate the interaction with the size of the side branch, less than 225 or more than 225. No interaction in all these subgroups.
Okay. So this is very much in accordance with the initial Nordic study way back, when anything other than TIMI zero flow was basically left to look after itself. Yeah.
I have a technical question. With 98% of the pot, what percentage was really not optimally performed? Do you have any insight information? Because we keep advising find the best projection, be careful of the position of the marker just in front of carina. So if it's routinely done in practically 600 patients, does it mean that people are trained to do it properly, or the relevance is not so high?
It's difficult to control what is a perfect pot in terms of core lab analysis. What we have is the ratio between the size of the balloon and the artery diameter by core lab. So for these numbers, for these figures, it's okay. It's a nice ratio. But of course, the second key point in the pot is the location of the distal part of your balloon and the relationship with the carina. And this is a thing which is extremely difficult to evaluate by core lab retrospectively.
I know that Yoshi published a lot. Yoshi, would you comment on that?
According to the pot balloon location, we can discriminate the good pot or bad pot. Bad pot promote the proximal wiring, and the stent malposition is increased. So our propot study is 30 to 40% has insufficient expansion in the polygon area. Insufficient polygon area, and subsequent side branch dilation, pot side sequence increase the bifurcation stent failure more. So sufficient expansion in the polygon area, we should confirm such kind of thing when we perform the pot side pot procedure here.
Giuseppe.
I have a question for you, Bernard. Congratulations for running this trial. So actually, I've seen that this is an intention to treat, but also you have also the protocol analysis. Actually, I didn't have the time to see the number because, the sake of time. But actually, my question is, how much was the percentage of crossover from, simple provisional without any treatment of the bifurcation versus the other arm?
2%.
2%. This is mainly visual. The approach was visual.
The crossover was made on operator, it's a left to operator, visually by left to operator decision. And it's most of them were due to some flow reduction which appears after the main stenting, but 2% was extremely low.
Okay, I have another point for Stefan, if I have the time. So actually what is interesting about this FFRangio is the following, not only to make the diagnosis, but actually when you have already decided to do PCI, Goran, I don't know what you think, you do the PCI, angio-guided, but actually when you go for angio-FFR to evaluate the result of angiographic, of the outcome, this is very important because what we use generally with the invasive physiology is to do the physiology before, but most of the time we do not complete, doing the physiology after the stent. In this case, I think one of the step forward of having this non-invasive evaluation is to make the evaluation of an angiographic approach, angio-guided approach, to see if the final FFR is good, because if you stay below 89, the result is not there, I don't know what you think about that. A key lecture, might be a key lecture of this kind of technology.
It's true, it's something extremely useful. Don't know if it works. Yes, it's extremely useful because at the end of your nice bifurcation, you want to end up the procedure and you don't want to re-inject to measure FFR. So it is extremely useful. We are using it. There is also something which is extremely useful when you prepare your dilatation. You have also some insight about how focal or how diffuse is the disease. Because you saw on the right side of my slides, it's like if you do a pullback, you notice new metrics such as the PPG. These are also some information that you get with this FFRangio. It's extremely useful.
Yeah, to answer Giuseppe directly, I have concerns regarding pre-PCI evaluation of physiology, because plaque is usually continuous and it's very difficult to split the impact of one versus the other vessel. But at the end of the procedure, after removing lesion from the main vessel, I believe it's reliable, and probably for me this is the main...
It's a kind of double check that you can do just before finishing to say actually also from the physiological point of view without taking out any
Exactly, and to have confirmation. And what I like very much, Stefan, in your presentation is that there is consistent non-invasive versus invasive evaluation. All the numbers are really very comparable. Dave has a question.
I have a question.
Yes.
So tell me if I got this right. So the recommendation, if you like, sort of not necessarily to consider kissing, is based on the fact that the troponin results are the primary endpoint. Yes, so you're chiefly focusing on that. But there are situations, aren't there, where the diagonal, let's say, for example, is 90% narrowed and can be an angina-producing lesion in its own right, which I guess this study hasn't necessarily tested yet. So I'm trying to prompt you to suggest that there are situations where a kissing balloon inflation is a sensible thing, because you've got a large enough diagonal that is 90% narrowed over 5 millimeters and will potentially continue to give the patient angina from a 10% myocardial ischemia.
We evaluate the angina. I did show that because I don't have enough time to show all the different endpoints. And there is no significant difference. There is a small trend in the wrong direction regarding side branch. So I think, and again, I think these results are promoting a little bit more pod-side pod than kissing. If you have to do something.
But it's non-left main, so...
In non-left main. Non-left main. But that's why I said we have to do kiss left main.
But there are, of course, you won't be able to see it in the whole data, but would you say that there are side branches that you would like to intervene on after placing the stent and doing a pot-side pot?
As I said, there is no interaction between the size, the degree of stenosis and the outcome, and there is no interaction between the size of the branch, the diameter of the side branch, and the outcome. So there is no reason to think that you have a better outcome in large side branches, for example, compared to small side branches.
Okay, he's not for budging, is he?
There is a question. If we have the sediment dilation, your data is pot-side pot better than Kiss-Barre inflation. So you recommend the pot-side pot for the sediment dilation?
I think it's not the target of the trial. It's clearly it's just a hypothesis generating data, so we have to consider that because we are comparing two types of intervention in the control group, which were not randomized, but we observe this strong trend. So clearly it's hypothesis generating, and if we want to have a clear answer, you need again to randomize.
And another question is, please advise the appropriate pot avoiding the sediment compromise.
It's a good question, but I think you have the answer. I think with a proper trial, we have definitely good data to answer to this question.
Other questions or comments?
From the audience, probably.
Yeah, whilst they're thinking, do you find that pot-side pot, the final pot, I mean, the positioning of the balloon has to be very precise,
Yeah.
doesn't it?
Yeah.
So is that a potential problem? I mean, if you're not aware how careful you have to be with the positioning of the second pot balloon, could you possibly cause problems?
Yes, of course.
Yes.
I think it's very important to have very precise location. You need to know exactly where are the shoulder of your balloon compared to the markers of your balloons. That means that you need to know very well your balloon you are using for this second pot. And you need to go up to the carina, which is not the case when you do double stenting, where you should do a more proximal pot. So it's also very important to find the right view, except if you use OCT, but we have to find the right view to be sure you have good discrimination between the two branches. So a lot of attention should be done for that.
To Goran, I have a point for you, Goran.
Yes.
So actually, pot-side pot, many of these techniques are mainly based on angio-guided PCI. But when you go for imaging, can you get rid of, in some cases, of all this repetition, pot-side pot, etc.? Because it might be okay with the first pot and that's it. I don't know, what is your thinking about? Because we are encouraging people to do imaging, but when we see what we do, is it really necessary to follow this sequence in all cases?
Yeah, thank you, Giuseppe. I don't think it's really easy to answer that question. Why I'm believer in use of imaging and image guidance. I'm also sure that addition of physiology may help optimize the result, because we really have Renovate complex that was just published in New England. We are waiting at ESC Illumin 4 with clinical outcome, with hard endpoints as the primary endpoint, image guidance versus no image guidance. And I believe if also that evidence fits that by doing imaging and optimizing procedural result, we improve the outcome in regards of the hard events, mortality, myocardial infarction, that will really justify extra time and extra effort to optimize result with imaging. And so far, all the evidence is really convincingly going in that direction. We also have October. I don't know when October will be presented.
October.
October, yes. In
It was supposed to
October.
be a joke, but it really fell flat.
So they will present at TCT or
Yeah, in October. Yeah.
in October. Okay, so
We got there in
October,
the end.
October will be in October at TCT. I think after these two trials, we will have more, yes, in order to change the guidelines and modify the practice. I would like to thank you all. I would like to thank the people who kindly attended this session at the end of a long day, the first day, busy day with many studies. I'm sure we learned today the value of new generation drug-eluting stent with excellent expansion capacity to feed the left main, and we have 2 trials which convincingly demonstrated that by using this newest generation stent and provisional stepwise strategy for side branch approach, we can improve the outcome and promote stepwise provisional as a standard strategy also for left main. I also learned a lot about the potential use of FFRangio, and I see in the future a lot of applications, including bifurcations, especially to evaluate procedure and optimize procedural result. And I'm not happy, but I learned also that outside of the left main, kissing routinely is not recommended. But there are some instances, as Dave said, and I agree, that large diagonal with 90-degree stenosis may be individually assessed, and maybe kissing could be done. Thank you very much for attending this session.